In patients with
he has been publishing in intensive care medicine for the last years, many publications, many topics. He has done a lot of COVID research, like many of us over the last years. But now he is talking about something that has been on his CV and on his publication list several times over the last research, like talk, and we will also have a little discussion within the talk. So it's very well recommended to already start putting in the first questions during the first slides. Okay, I think we can start. We begin with Professor Son Mil from Paris. He has been publishing in intensive care medicine for the last years, many publications, many topics. He has done a lot of COVID research, like many of us over the last years. But now he is talking about something that has been on his CV and on his publication list several times over the last years, speaking of bacterial meningitis and encephalitis, viral encephalitis, and he will give us an overview on how to make the diagnosis and treat those infections. Please. I think you have to unmute yourself.
Sorry, can you hear me now? Yeah.
Now it's perfect.
Thank you very much, Matthias, for the very kind introduction. It's a pleasure to be here to attend this webinar organized by the ESICM. This is my conflicts of interest slide. And I would like to start with meningitis. Meningitis is an important problem when talking about CNS infection. It's basically a syndrome caused by an inflammation of subarachnoid space, which is usually caused by infections, viral infections, or bacterial infections. The most common symptoms include fever and meningism, but in severe cases that we see in the ICU setting, altered mental status, focal signs, or seizures can occur in adult patients. When we speak about the importance of the topic, we know that bacterial meningitis remains a worldwide health problem. The incidence rate is declining in high-income countries, being approximately 1 case per 100,000 individuals per year. And it's still associated with severe outcomes in the form of persistent disability in survival and high mortality rates, especially in intensive care patients. So basically, bacterial meningitis is caused by an infection of the CSF filled subarachnoid space, as you can see here on a sagittal section of the brain, with bacteria usually reaching the meninges through the blood-brain barrier. Common symptoms are caused by CSF inflammation in the form of fever, headache, and neck stiffness. But in severe cases, as we know, patients may develop altered mental status, focal signs that are usually explained by contiguous extension of inflammation or by indirect complications, mainly vascular complications. Here's a picture of common pathogens seen in adults with acute bacterial meningitis. This is a very interesting epidemiological study conducted by the group of Diederik van de Beek and colleagues in the Netherlands, where you can see that in adult patients, Streptococcus pneumoniae and Neisseria meningitidis account for approximately 80% of etiologies, of bacterial etiologies. Streptococcus pneumoniae in dark blue is even more frequent in patients with comorbidities, such as patients with diabetes, patients with chronic alcohol consumptions, cancer patients, and patients under immunosuppressive therapies. Another important pathogen is of interest in immunocompromised patients, Listeria monocytogenes, which is almost exclusively observed in those patients with chronic comorbidities. As you can see on the slide, other bacteria such as Haemophilus influenza, E. coli, or Streptococcus agalactiae have very low frequencies in adult patients. It is very important to highlight the fact that despite advances in treatment of infectious diseases and critical care over the 20 last years, pneumococcal meningitis in adults remains a very severe disease associated with significant morbidity or mortality. This is the latest data, again, from a Dutch cohort, showing that approximately 40% of patients have persistent disability or death after several months. And deaths resulting from severe neurological complication, generalized brain edema or cerebrovascular complication remain very common in this population. This is just a snapshot of the clinical presentation, different European cohorts showing that common symptoms are not frequent and can be missing. For instance, the common triad of fever, neck stiffness, and altered mental status is observed in less than 1 out of 2 patients in these different cohorts. The one important thing when you think about clinical examination and bacterial meningitis, please pay attention to classic clinical characteristics, as some of them may be absent. And it is clear that bacterial meningitis should not be ruled out solely on the absence of classic symptoms such as headache, meningism, or fever. What about cranial imaging? Of course, ruling out bacterial meningitis requires lumbar puncture for CSF examination, and some patients may require cranial imaging before LP. This, again, has been largely evaluated in previous studies. These are the grade A recommendations for performing cranial imaging before LP in adult patients. This is recommended only in patients with focal neurological deficits, new onset seizures, severely altered mental status, or in patients with pre-existing immunocompromised states. The main message is that in patients lacking this characteristic, cranial imaging is not recommended, as it is associated with a significant delay in the starting antibiotic treatment. I don't have to go into details, but other common contraindications include, of course, anticoagulant therapy and low platelet counts, as depicted here in this very nice review published in Lancet Neurology in 2018. So clearly, lumbar puncture is key. This is the typical macroscopic examination of purulent CSF on the right part of the slide, as compared to normal crystal clear CSF examination in the patients with a suspicion of bacterial meningitis. The opening pressure is typically high. The macroscopic examination shows cloudy CSF with very elevated cell counts, predominance of neutrophils, and low to very low CSF to plasma glucose ratio with elevated protein levels. Of course, none of these biochemical parameters is highly sensitive or specific to confirm or rule out the diagnosis, and microbial examination is, of course, of utmost importance. What about gram staining in this context? This is data from a very large cohort of patients with confirmed bacterial meningitis. You can see that gram staining has a sensitivity of 80%, specificity of 97% in this large multicenter cohort. Interestingly, the yield of gram staining is similar in patients who had received antimicrobial therapy and those who had not. And pay attention to blood cultures before starting antibiotic therapy, as these bacterial examination can be positive in approximately 2/3 of patients. What about other tests? Multiplex PCR systems have been developed over the past years. This is the FilmArray multiplex PCR system, which can, in a point-of-care device, detect up to 14 different pathogens in 1 hour. And this panel of microbes includes common bacteria associated with community-acquired meningitis in adult patients. So it may help to diagnose or rule out this type of infection in the emergency room or in the ICU setting. But if you take a closer look to data published in patients with confirmed bacterial meningitis, we can see that the sensitivity and specificity looks good, but it's based on a relatively low number of observations. This is one of the seminal paper published in the field. There are other papers, but still the number of cases is quite low, and the 95% confidence intervals that you can see here are quite wide. So maybe we need a little bit more of data, of confirmation data, to make sure that we can use this to rule out or confirm a diagnosis of bacterial meningitis in a patient, for instance, with a negative gram staining at ICU admission. Very important point is that the earlier the treatment, the better the outcome. This is one of the large multicenter studies conducted in the field, showing the association between the probability of poor outcome here, that is hospital mortality, as a function of time to treatment, time between hospital admission and first dose of cephalosporins. And you can see that any hour of delay is associated with a relative increase in mortality of more than 12%. So again, from the guidelines, antibiotic therapy should be started as soon as possible. The time window should not exceed 1 hour, and whenever lumbar puncture is delayed, mainly for performing cranial CT, please start empirical treatment immediately based on clinical suspicion, and then perform the lumbar puncture to rule out or confirm the diagnosis, especially in severe patients. So this is the top 3 points for initial management in the ICU setting: blood culture sample, lumbar puncture unless contraindicated, start antibiotic therapy as soon as possible with adjunctive dexamethasone in selected patients, and consider early ICU admission for detection and management of associated complications. What about empirical antibiotic therapies in this context? The main antibiotic drug is cefotaxime that should be prescribed in intermittent infusion in 4 divided dose, 200 milligram per kilo per day for all patients. And in countries where the prevalence of cephalosporin-resistant pneumococcus is high, you should consider adding vancomycin or rifampicin to your cefotaxime regimen. In patients presenting risk factors for listeria infections, amoxicillin, high-dose amoxicillin should be added to the empirical treatment. Please remember that beta-lactams are time-dependent antibiotics, and you should be able to spend the maximum of time above the MIC, which is associated with bacterial killing and clinical cure. And there is data suggesting that continuous infusion might be beneficial in patients with bacterial meningitis. Another important point is the pharmacokinetics of the severe patients with brain injury in patients with bacterial meningitis. It has been well documented that increased renal clearance is observed in 1 out of 4 patients, and this may result in inadequately low concentrations of cephalosporin at the acute phase. This is summarized here. This may result in treatment failure, clinical worsening, and by contrast, in patients with sepsis and associated renal failure, high-dose beta-lactams may be associated with a high plasma concentration and an increased risk for neurotoxicity, which will develop in the form of persistent encephalopathy and a higher risk of seizures. So in this context, the only way to be sure to treat patients adequately is to perform therapeutic drug monitoring for beta-lactams. What about antibiotic de-escalation? In community-acquired meningitis, for most patients, we will be able to de-escalate to more simple antibiotic therapy, penicillin or ampicillin, and the duration of treatment is short for Neisseria meningitidis patients, 5 to 7 days. A longer course may be necessary for pneumococcal infections, 10 to 14 days, and for Listeria, 21 days of antibiotic therapy is still recommended. What about corticosteroids in these patients? That is just a summary of available data showing mortality risk reduction, which is only significant in patients with Streptococcus pneumoniae meningitis. But it is not only associated with reduced mortality, but also with neuroprotection for hearing loss and functional disability in patients with all-cause bacterial meningitis. Of note, the beneficial effect is only seen in patients treated in high-income countries with large access to critical care services. These are the recommendations for adjunctive dexamethasone, which is strongly recommended. Again, grade A recommendation, 10 milligram every 6 hours for 4 days. And this should be started again with the first dose of antibiotic treatment. This is a summary of initial intensive care management. Early ICU admission may be necessary for tier 1 measures to control cerebral edema and raised ICP in this setting. And also for detection and management of associated neurological complications. We don't have to go into details, but the most common complications include brain infarction, hydrocephalus, cerebral empyema, and seizures that are detected in approximately 20% of patients at the acute phase. A simple clinical message in comatose patients with bacterial meningitis is to perform a CT scan that should be obtained without delay, especially to identify complications that may require neurosurgical interventions. These complications are not frequent at ICU admission. You can see here, again, a study conducted in pneumococcal meningitis patient, but these patients will require emergency neurosurgery in addition to antibiotic therapy, dexamethasone, and supportive care. So to summarize the first steps of management of acute bacterial meningitis in ICU patients, Streptococcus pneumoniae is the most common pathogen and associated with the worst outcomes in the form of neurological complications and mortality. Early antibiotic treatment is mandatory within 1 hour following admission, together with adjunctive steroids. Please pay attention to detection and management of neurological complications. And data from ICU studies suggest that approximately 20% of comatose patients at ICU admission will make a full recovery.
Well, thank you for this wonderful first part of your talk. We have a couple of questions in the chat, and I will read them to you. First question and remark: many cases present with sepsis and disturbed consciousness. Lumbar puncture is sometimes not feasible. any guidance how CNS infections to be covered? So what would you treat the patient with in sepsis and you cannot rule out because you can't do the lumbar puncture?
That's a very good practical question. Of course, lumbar puncture cannot be easily performed in unstable patients, such as patients with septic shock. So if you have a suspicion of bacterial meningitis, of CNS infection in general because of altered mental status and signs of sepsis, I think a good clinical rule would be to start high-dose cephalosporin to reach adequate meningeal concentrations, stabilize the patients, treat septic shock, and once you can do the lumbar puncture and you're able to rule out or to confirm bacterial meningitis, then you can adapt your initial dose of antibiotic treatment. That is a very important question, I agree.
Thank you. Next question, it goes a little bit in the same area. So are there any alarming signs for CNS infections in pneumococcal pneumonia, or do they differ? Do patients with pneumococcal pneumonia differ from other meningitis patients? So when do you think about meningitis if there's pneumococcal pneumonia?
So it's again a tricky question because we know that severe pneumococcal pneumonia may be associated with signs of sepsis, including sepsis associated encephalopathy. But we also know that Streptococcus pneumoniae is a neuroinvasive pathogen and may be associated, of course, with bacterial meningitis. So I would say that the threshold for performing a lumbar puncture in the patients with pneumococcal pneumonia should be very low because it will dramatically change your management if you diagnose CSF inflammation associated with pneumonia. First of all, you will increase the dose of antibiotic therapy. You will use high-dose cephalosporin. You should discuss adjunctive dexamethasone, and you should look for associated complications as well, such as bacteremia and endocarditis, for instance, or other systemic complications associated with invasive pneumococcal infections. So, yeah.
Yeah, so I think you also said it in your talk. So the threshold for doing the lumbar puncture should be low, and in most cases we will exclude bacterial meningitis, thankfully. But in those where we find that it really makes a difference. There's another question in deciding the opening pressure. Would there be a significant difference for lateral versus sitting lumbar puncture? And maybe my question to the expert, do you really do a measurement of the opening pressure in all those patients?
This is a very, again, very good question because there is a lot of data showing that elevated opening pressure is associated with poor outcome. It identifies a group of patients with a higher risk of neurological deterioration and complications. I would say that in France, we are not really good at measuring opening pressure in the emergency department. So most of the calls we receive, the patient is, the doctors have a suspicion of bacterial meningitis, lumbar puncture has been performed, and most of the time the opening pressure has not been measured in the emergency department. So the initial pressure level is usually not available. When we repeat lumbar puncture in the ICU, we are used to measuring opening pressure in lateral position, but we don't have to repeat CSF examination all the time. So usually it's very difficult to include these pressure levels in clinical practice. I know in other countries it's more systematic to perform opening pressure measurements irrespective of the diagnosis suspected.
All right. So before we go on, very short answers to some more quick questions. So first of all, maybe for pneumococcal meningitis and meningococcal meningitis, how long should you go on with the antibiotic treatment?
Antibiotic treatment for pneumococcal meningitis, usually a 10-day course is recommended and enough, 10 to 14 days. That's what is written in the guidelines. And for meningococcal meningitis, short courses of antibiotic therapy have been proposed, 5 to 7 days. So it's getting shorter and shorter.
Yes. Last question, does CT head with contrast help to diagnose meningitis?
How to diagnose? Sorry.
No, does CT head, cerebral CT scan, if you add contrast to the CT scan, does it help you to diagnose bacterial meningitis, or is it not useful?
Again, a very important point. The CT with contrast will help with the diagnosis of associated complications. For instance, a minority of patients develop cerebral vascular thrombosis associated, cerebral venous thrombosis associated with bacterial meningitis, and this diagnosis require CTA. Infarction, vasculitis may also be diagnosed with contrast. And CT is also important for diagnosis of the source of infection. For instance, in patients with complicated ear infections such as mastoiditis, CT is of importance, as patients may require additional surgery. And this is approximately 10 to 50% of cases in the study I showed previously.
Okay, thank you very much. There are a few other questions, but I think we have to go on because there is I think, very high probability that the second part of your talk is also very interesting, and we don't want to miss it.
Thank you. So we move on to the second part. So encephalitis. Again, it's a syndrome. It's a syndrome of brain inflammation, which is usually caused by infection, mainly viral infection. And when we think about encephalitis, we think about the neurotropic viruses, herpes simplex encephalitis. It is less frequently caused by immune-mediated disorders, but this etiology has been increasingly recognized in the ACU setting. Symptoms include altered mental status and fever, with a combination of meningism, focal signs, and seizures that are really non-specific signs. And you can see here a typical presentation of herpes simplex encephalitis on a flare-weighted image with a typical temporal lobe involvement here on the right part of the brain. What about definitions? A clinical diagnosis of encephalitis requires acute onset of encephalopathy, altered level of consciousness, personality changes, short-term memory deficits lasting at least 24 hours, with a combination of supportive elements that are, again, really non-specific, new focal CNS findings, new onset seizures, fever, CSF pleocytosis, and brain imaging abnormalities or EEG alteration that are consistent with the diagnosis. Of course, if you apply all these criteria to patients in the emergency room, what you will get is that you will more often suspect encephalitis, but you won't confirm it. And it is very important to rule out the most frequent differential diagnosis. in this setting. And for instance, stroke complicated with aspiration pneumonia, systemic infections, metabolic disturbances, toxic exposures are much more frequent than viral encephalitis in the emergency room setting. This is clinical pictures of causes of encephalitis in Europe. This was conducted more than 10 years ago by a British group. Prospective data showing that infections account for 40%, 42% of causes, immune-mediated causes 21%, and approximately 1/3 of patients still have a known etiology at the hospital discharge, despite extensive investigations. If you take a closer look at immunocompetent patients, top 5 diagnoses include herpes simplex viruses and non-infectious causes in the form of acute disseminated encephalitis and encephalitis associated with antibodies. Other causes, such as Mycobacterium tuberculosis and VZV, are less frequent and especially seen, as you know, in patients with comorbidities. Briefly, this is data from a large French multicenter cohort performed outside the ICU setting, including both non-ICU and ICU patients. You can see here in terms of percentage of cases with an identified cause that herpes viruses, HSV and VZV account for 60% of identified causes in the general adult populations. Other causes are less frequent and include not only viral causes, but again, bacteria such as Listeria, Mycobacterium tuberculosis, but the percentage are much lower than the common viruses. Again, from this recent study, you can see that approximately 1/3 of patients still have an unknown etiology at hospital discharge. Practical approach include a medical history that can help with the suspicion of specific causes, for instance, in immunocompromised patients, in patients who recently traveled or had contact with vectors, animals, or insects. Clinical examination should pay attention to identifying patients with non-neurological signs associated with encephalitis, such as skin rash, such as interstitial pneumonia, which may be associated with specific causes. And the multimodal evaluation, including CSF serum studies, to rule out common infectious cause and common immune-mediated cause is mandatory, in line with brain imaging and EEG studies that are recommended for the syndromic approach. Acyclovir therapy should be initiated in all patients with suspected encephalitis, because the diagnostic approach may require days to weeks, and you should not miss important viral causes that require specific therapies. I will skip this, I think, but there is accumulation of data suggesting that in patients with severe viral infection, in severe HSV encephalitis, delay in starting antiviral therapy is associated with an increased risk of poor outcomes. So we should not wait. CSF interpretation is non-diagnostic, showing usually slightly increased cell counts, predominance of lymphocytes, normal CSF to plasma glucose ratio, and normal or to moderately high protein levels. Systematic routine studies have been proposed for patients with a known cause of encephalitis, and these include, of course, the common pathogens that are detected in large epidemiological studies. And in immunocompromised patients, of course, additional causes should be ruled out, and remember that one given patient may have not only one cause, but sometimes 2 or 3 causes. Dual findings have been shown to be present in 10% of immunocompromised patients with encephalitis. So again, the evaluation include routine studies, and you should add conditional studies in patients with specific host factors, geographic factors, season and exposure, etc. And in case of extra CNS involvement, please pay attention to non-neurological samples such as skin biopsy, bronchoalveolar lavage in patients with pneumonia, which can add important information to the diagnostic strategy. The multiplex PCR, again, may help with ruling out viral causes of encephalitis in this setting. If you take a look at the data, sensitivity and specificity, it looks pretty good, with the notable exception of enteroviruses and HHV6. And this was confirmed by other studies. There is clearly a lower sensitivity and specificity in these for these viral causes. Metagenomic has been proposed to diagnose patients with unexplained encephalitis after first line and second line investigations, and data from this study suggests that it can detect infections in about 22% of patients where investigations were not able to diagnose an infection by conventional testing. But this is not performed in first line. This is not performed in all centers. This still requires confirmation, but it's a very interesting investigation in this group of patients. Neuroimaging is mandatory for this type of syndrome. MRI has been recommended for a long time in guidelines because it's more sensitive and specific, especially as it is specific patterns may be diagnosed with these common MRI sequences. I will just show one or two examples. This is a typical pattern that is associated with herpes simplex infections. And by contrast, the autoimmune pattern seen here on the FLAIR-weighted imaging, bilateral temporal lobe involvement that is independently associated with non-infectious cause with autoimmune cases in this large multi-center study. EEG is also part of the diagnosis. I have to keep this short, but specific patterns have been shown in or detected in patients with viral encephalitis. This is a typical pattern of periodic discharges that is seen in patients with HSV1. It is not specific, but it's clearly strongly associated with HSV1 etiology and associated with an increased risk of adverse outcome. I will not focus on HSV encephalitis as it's mainly, most of the time not very difficult to diagnose, but remember that atypical presentations have been documented in the literature. For the treatment of herpes viruses, acyclovir therapy remained the cornerstone, 10 milligram per kilo every 8 hours in patients with normal renal function for a duration of 14 days in the absence of immunosuppression. In patients with VZV encephalitis, higher doses and longer durations of treatment have been proposed by experts in the field. I will end my talk with discussing an important differential diagnosis. Antibody-mediated encephalitis are been described in the ICU setting, especially those associated with cell surface antigens. The most common pattern and the most common cause of immune-mediated encephalitis is the one associated with antibodies targeted to the NMDA receptor. Those patients usually present with severe neurological dysfunction and normal brain imaging. Typical EEG patterns have been also described in this setting and may help with the clinical suspicion and with in the differential diagnosis. Again, this is of utmost importance to identify those patients, as we showed in a previous study with Etienne, that the only modifiable factor associated with outcome at 6 months was the early instauration of immunotherapy, basically before or following 1 week of ICU admission. This was associated with both improved outcomes and a faster recovery in patients who eventually recovered. This data on combination therapy has been confirmed in a large meta-analysis, where you can clearly see that compared to steroids only, combination therapy, corticosteroids plus IVIG or therapeutic apheresis is independently associated with improved outcome at 12 months. This is data from the latest guidelines. First-line treatment should include a combination of corticosteroids plus IGIV or PLEX, followed by second line to be discussed based on experts' opinion in refractory cases. So to conclude with this, viral encephalitis is mainly due to neurotropic viruses. The treatment is based on intravenous acyclovir, as you know, which should be started within 6 hours based on clinical suspicion. Pay attention to other specific causes, especially in patients with immunocompromised status, in patients who traveled or in different areas of the world. There is a clear guideline for a diagnostic algorithm based on brain imaging and CSF, PCR, and immunology tests. And remember that if there is no infectious cause, immune-mediated encephalitis should be considered, as it represents approximately 20% of diagnosis in the adult population in the ICU setting. And with this, I would like to thank you for your attention, and I will be again open for questions. Thank you very much.
Well, thank you very much for this very nice, interesting second part of your talk. I can see here is one question in the chat. Does COVID cause, or does SARS-CoV-2 cause encephalitis? So back to the topic.
But it's it's a very important question, because we also a lot of neurological complications associated with COVID. So the most frequent neurological complications of COVID are acute encephalopathy associated with severe respiratory illness. But some patients may develop more complex complication, and some patients will meet the criteria for probable encephalitis with persistent encephalopathy, CSF changes, focal signs, seizures. Usually, there is no neuroinvasion detected. All studies conducted to date show that RT-PCR done on CSF do not detect SARS-CoV-2 in the brain. And most brain imaging studies suggest that encephalitis associated with COVID-19 is more a post-infectious disease, and patients usually presenting features of ADEM, for instance, acute disseminated encephalitis. So yes, it exists. It's a rare complication, but given the fact that we saw many COVID-19 patients, we feel like we saw a lot of encephalitis associated with COVID, but I think it's a relative observation compared to the absolute number of cases.
Thank you very much. Maybe one question to the in terms of the autoimmune encephalitis patients linked to herpes simplex virus encephalitis. Is there indication to treat HSV encephalitis patients with steroids to lower the risk for autoimmune encephalitis?
It's a very interesting question. Though we don't have data to recommend to use adjunctive dexamethasone, for instance, to standard acyclovir therapy at the acute phase. There are ongoing trials on the topic. There is a trial called DexNCEF, which is about to end. So I think we will have data soon, but we cannot recommend this. NMDA receptor autoimmunity has been documented after a confirmed HSV encephalitis. So HSV encephalitis is a trigger for NMDA-mediated autoimmunity. So in patients deteriorating after HSV encephalitis, and in those patients, if they show features of inflammation, brain MRI changes, neurological deteriorations, you should look for NMDA receptor antibodies and discuss empirical immunotherapy if the diagnosis is right. So it's a rare but now well described complication of HSV encephalitis. I agree.
Thank you very much. There are actually a number of questions now in the chat, which is pretty good. So I will try to catch one more. Maybe a general question. What is the role of repeating lumbar puncture in monitoring treatment response? It's very broad and probably a question for many different CNS diseases or infections. Okay,
so I will try to keep this short. For bacterial meningitis patients, repeat lumbar puncture is not recommended in patients who have, let's say, non-resistant strains of pneumococcus. If you have a good clinical evolution under antibiotic therapy, repeat lumbar puncture is not recommended. Repeat lumbar puncture may be recommended in patients with difficult to treat pathogens, but studies conducted irrespective of the pathogens show that usually cultures are sterile after a couple of days. Direct examination may still show bacteria, but the bacterial growth is 100% negative in repeat lumbar puncture, and the prognostic significance of repeat lumbar puncture has not been extensively studied as far as I know. In viral encephalitis, we are used to repeating lumbar puncture after 14 days in patients with persistent fever, CNS dysfunction. If CSF PCR is negative for HSV, we are used to stopping the treatment. And if it remains positive, we don't really know what to do with qualitative PCR assessments. So it's a matter of debate. But we never systematically repeat lumbar puncture in patients. It really depends on the evolution.
Thank you very much. Maybe one last question picked out of many of questions that came up on the chat is the indication for treatment with immunoglobulins in suspected autoimmune encephalitis. Maybe you can stretch a little more on when the diagnosis of autoimmune encephalitis can be made to actually justify treatment, or do we start treating patients for autoimmune encephalitis if the panel is back negative?
It's a very good point. I think the thing is, if you have a suspicion of autoimmune cause, you should not wait for the results of antibody testing to decide to treat patients. What experts suggest is that if you have a clinical syndrome compatible with autoimmune encephalitis, and if you have a reasonable exclusion of common infectious causes by any means, if you don't have an alternative diagnosis, then you should consider starting early immunotherapy. And we lack data about first-line treatment and how to use them. I mean, we don't have high-quality data, but the standard of care in those patients is, experts suggest that the standard of care should be early combination therapy in severe patients. Steroids plus either intravenous immunoglobulin or plasma exchange. I'm not 100% sure that plasma exchange and immunoglobulins are comparable in this setting, but if you take again a look at the guidelines, that's what the guidelines suggest. But we lack high quality data on immunoglobulin therapy in patients with suspected or confirmed autoimmune encephalitis. I agree.
Well, thank you. Maybe in this point that you just pointed it out, it's very important. The clinical syndrome, look at the patient, and the development of autoimmune encephalitis really differs from acute viral encephalitis. And it's not only the CSF parameters or the MR imaging results. So please keep that in mind. It's not only what you get from the laboratory.
I agree.
Well, thank you very much, Professor Sonville, for this wonderful talk. We could keep on the discussion for much longer, but we have a very interesting second talk in our session today. And I would like to welcome Dr. de Montmolin, also from Paris. He's also been publishing over the last years very extensively in various fields of intensive care medicine. And he also did some very nice works on CNS infections. And I'm very, very happy that he's here and sharing a case with us where you can also put in your opinion by using the polling function, which you also find on the right upper corner, where there's also the Q&A thing. So please keep on typing in your questions, participate in the polling, and I'm very happy to hear the next talk.
Okay, thank you very much, Matthias, for the introduction. Welcome to all. We will do a clinical case debate, and for approximately 35 to 40 minutes, we will discuss a case. I have 4 questions with polls, so I hope there will be much interaction. And so now let's start. First of all, the clinical case. You see at the emergency room of your hospital a 47-year-old male. He has acute onset behavior disorder, and his wife reports worsening episodes of agitation for the last 5 days. When asking for his medical history, you learn that he's a heart transplant recipient from 3 years earlier for idiopathic dilated cardiomyopathy. He also has hypertension and a mild chronic renal failure. Regarding the transplant treatment, he takes daily 10 milligrams of prednisone, 150 milligrams twice a day of cyclosporine, and 1 gram twice a day of Cellcept. At the emergency room, his vital signs are 120/70 of blood pressure, a heart rate of 110. He has a 98% saturation on ambient air, and he is febrile with a body temperature of 38.9 degrees Celsius. On physical examination, you have a drowsy patient with a Glasgow score of 14. He loses 1 point on the eye component. He has headaches, and you notice temporal disorientation. You don't find any motor or sensory dysfunction. He has no neck stiffness, and there is no other physical abnormality. In this context, you perform a lumbar puncture, and you have here the results of this first lumbar puncture. There are 6 cells per cubic millimeters, slightly increased protein levels at 0.9 gram per liter, normal glucose level, CSF glucose level, and the negative gram staining is the gram staining, is negative. So we launched the first question, and it's rather broad. So it's a multiple choice answer, and the question is, what are your main diagnostic hypotheses at this stage? You have the choice between steroid-induced psychiatric disorder, possible encephalitis, posterior reversible encephalopathy syndrome due to calcineurin toxicity, probable encephalitis, and finally, extra neurological bacterial sepsis. So you may choose more than one answer. You turn to play.
Okay, so we're having the polling now. Please participate, put in your answer. So, can you see the results, Etienne?
Yes, I can see them. It's moving. It's moving.
Okay. Perfect. I think we are already having a clear tendency, I would say, to a couple of preferred answers. Maybe you want to start commenting already,
sure.
Because I think we don't have to wait the time until everybody put in his mark.
Yeah, sure. So for the moment, the leading answer is possible encephalitis, followed by probable encephalitis, and last is steroid. So an extra neurological bacterial sepsis is 25%. So maybe I will show you the answers, but maybe I'll wait just a little bit more. So some of the answers are wrong, but some are indefinite. It means you can see medicine is a gray area. So some answers I would say can be true. It's a question of probability. So don't be angry if I say one of the answers is wrong and you said yes.
We will not tell anybody, and we cannot see who answered in which way. So there is no reporting to your boss or colleague. It's a very anonymous thing.
Okay,
so I like your suggestions, because actually we could discuss all of the answers in a very interesting way in the context of your patient.
So do you want me to show the answers now?
Actually, I don't know if we all are able to see or if we get to see the answers now. But maybe once again, I will read it to you so we can keep on. The possible encephalitis is the answer B is the winner here with 64%. Then D is probable encephalitis, 39%. That's the second choice that you picked. And number 3 is the PRES. And number 4 is an extra neurological bacterial sepsis. And the last position is the steroid-induced psychiatric disorder. Maybe we can move on to the next slide. Is that possible?
Yes, let's do it. So I considered the right answers to be possible encephalitis and extra neurological bacterial sepsis. The steroid-induced psychiatric disorder is less likely because the patient is under a very small dose of prednisone, and he's been under prednisone for 3 years, so it's rather unlikely. Possible encephalitis was the right answer. I'll explain on the next slide why. PRES due to calcineurin inhibitor toxicity could be a right answer. I put it as a wrong, but you could say it's right. You can't rule it out at this stage. The only thing is that the patient is febrile and he has normal blood pressure, so that's less in favor of this diagnosis. Although you can have stress without hypertension in the context of drug toxicity, but I consider it not to be a diagnosis at this point. And probable encephalitis is not possible at this stage. We don't have enough criterion. I will show that to you. And I'm a little bit surprised that extraneurological bacterial sepsis was only 25% of respondents with that. I think you need. It's already when you have a patient with an encephalitis presentation, it's very exciting, and you only focus on that. But sometimes, more frequently than not, patients have not encephalitis but an extraneurological sepsis, urinary tract infection, abdominal sepsis that can mimic encephalitis. So I think you need to keep in mind that patients may have bacterial sepsis of non-neurological origin, and you have to take the diagnostic steps to be sure that is not the case. So concerning the diagnosis of encephalitis, so this Romain showed you in part this definition from 2013. Our patient had a major criterion, that's the alteration of a mental status lasting more than 24 hours, but had only two minor criteria, that is the fever and the white blood cell count. Mind you, we lack some explorations to complete those criteria. But for the moment, he has one major plus two minor, so that's a possible encephalitis. So that was the right answer. And I want to bring to your attention that you have to validate the major criteria, and you have to exclude alternative cause. That is it's at the end of the sentence, but it's very important. And that's why I put the bacterial sepsis in the questions earlier. Okay, going forward with the clinical case. So your patient deteriorates and he presents tonico-clonic general seizures refractory to first-line and second-line treatment, benzodiazepine and levetiracetam. And you have to intubate the patient, and he's now deeply sedated. You perform further diagnostic tests, that is a cerebral CT scan without contrast, which is normal. There is no or limited blood inflammation with 8 giga per liter of leukocytosis, and the procalcitonin is rather low at 0.7 in the blood. The CSF culture is negative, and you perform a PCR, a multiplex PCR on the CSF. There are several panels, but this one included herpes simplex virus 1 and 2, varicella zona virus, cytomegalovirus, enterovirus, listeria, streptococcus pneumoniae, and Neisseria meningitidis. And this PCR multiplex is negative. So we're now launching the second question. What is your empirical treatment at this stage? So again, you can answer multiple questions. First answer is dexamethasone and cefotaxime. Second answer is amoxicillin and acyclovir. The third answer is both dexamethasone, cefotaxime, amoxicillin, and acyclovir. The answer D is a treatment of tuberculous meningitis with rifampicin, isoniazid, ethambutolone, pyrazinamide. And last answer is E, none of the above. I think you can now answer.
Yes, please go to your polls. I don't see the possibility to enter the answers yet, so please somebody help us and get the polls up on the screen. We would really appreciate that. Here we go. So now please type in your correct. So there's only one answer now, which is correct?
No, multiple answers are okay.
Okay, I can only enter one, I think.
Okay, so just one then.
So put in one. Okay, I see the trick. Yeah, very, very interesting point. So in this patient, you had the negative CSF studies from a microbiological point of view. So you didn't really trust it, this case, so you didn't rule out the infectious cause yet. What did you order? What's in the pipeline?
At this point, already? No, at this point, you can't rule out an infectious cause. No, that is not possible. You can rule out some infectious causes.
Okay, so maybe this is a little hint for one or the other. Answering the questions, we're getting a very clear picture already drawn here. And concerning the number of polls which came back, I think we can already go into answering the question. I will read the polling results to you. So first of all, the top response was answer A and B. So most of you are treating with cephalosporin plus dexamethasone plus amoxicillin plus acyclovir. So you don't trust the microbiological test results. 28% do not treat with any of the suggested agencies, and on the lowest ranking, it's the tuberculosis treatment. So the winner is a very broad treatment from the audience. Maybe you want to comment on this and show the next slide.
Yeah, thank you. That's interesting. It's our patient clearly is very worrying. You don't know what's the diagnosis. Is in a status epilepticus, intubated. It's nobody likes that, but that's not the reason to give all the treatments that are available. You have to take a step back and reassess. So my answer here was none of the above. And I'll explain to you why, of course. So first, for dexamethasone and cefotaxime, the patient has a lumbar puncture that is it's not suggestive of bacterial meningitis, okay? You have normal glucose level, you have very low protein levels, you have almost no meningitis, 6 cells per cubic millimeters. So, and you have a low systemic inflammation, and finally you have a negative PCR for pneumococcus and Neisseria meningitidis. So the probability of having here a bacterial meningitis is very low. I would say 0. So not the first answer. Second answer is more tricky because it's usually a package, amoxicillin plus acyclovir for encephalitis. But here, Listeria also has the CSF I showed you is not suggestive of bacterial infection by Listeria, and you have a negative PCR in the CSF. So Listeria can be ruled out now. So that's why answer B to me is not a good answer. Answer A plus B is too much. Answer D, of course, is not adequate because once again the CSF is not evocative of tuberculosis, and you have to rule out all more simple diagnosis before treating meningitis. Tuberculosis, CNS tuberculosis. So the right answer, I would say, would be acyclovir alone, and go and carry on with the diagnostic workup. And I had, this is what I just told you. I have one more point I wanted to make, is that on some multiplex PCR for CSF, for the film array, for example, you have cryptococcosis also available. You have to know that this PCR sensitivity, and you cannot rule out cryptococcosis just with this PCR negative. This is all the more important that maybe you know, maybe you don't know it, but cryptococcosis can present with normal cellular count. So it can be tricky, and this PCR is not sufficient to rule out cryptococcosis. Okay, so that's why I was talking to you about. That's the CSF presentation of infectious etiologies according to the type of pathogen. And here we have, you see, very low cellular count. You don't know for lymphocytes. You have a normal glucose level and normal to high protein levels. So our CSF analysis is consistent with the viral cause, not diagnosed yet, but it's possible. You see, bacterial is very different in the presentation. For tuberculous meningitis, it is usually lymphocytic meningitis, but with very characteristic low glucose CSF concentration, even lower than for bacterial meningitis. It's usually very low and very high protein levels. So not at all the CSF of our patient. For fungal causes, for cryptococcosis, you can have zero cells per cubic millimeter, but usually you have increased protein levels and a low CSF glucose. So here, the most consistent etiology was viral, considering our CSF analysis. This is to show you it's not an extensive list, of course. It's not possible to do an extensive list, but so our patient is a heart transplant recipient, and this is some usual etiologies of infectious causes in the solid organ transplant recipients. You have the usual suspects: bacteria, Streptococcus pneumoniae, Neisseria meningitidis, and also Haemophilus and Listeria, of course. Lyme disease is much less frequent, of course. And don't forget bacterial abscess, polymicrobial abscess. For viral causes, herpes virus are in the front line with herpes simplex, and also varicella zona virus. And you also have enterovirus that can be frequent. For fungi, keep in mind the first two of the list, okay? Cryptococcosis and Aspergillus. Those are the two main culprits you want to look for in patients with a solid organ transplant. Solid organ transplants. For parasites, it's the classic toxoplasmosis, and you always have to put Mycobacterium tuberculosis in your list of possible etiologies when considering a solid organ transplant recipient. To translate this slide into clinical practice, this is a rather recent publication in Journal of Infection of almost 5,000 transplant patients from Switzerland. They were followed for a median of 4 years, and they documented 42 CNS infections. And you can see here the repartition. So the most frequent causes were viral infection with VZV first. You have also EBV related with PTLD, so it's a post-transplantation lymphoid disorder. That's not typically a viral infection, but it's a cause. You have also HSV here and also enterovirus, as I mentioned. Fungal infections are a quarter of the cohort. You see aspergillosis and cryptococcosis. Finally, bacterial infections are more rare with particular etiologies for the transplant, for the solid organ transplantation, such as nocardiosis. That means you have to ask your lab for prolonged culture of your CSF. And what is maybe the most interesting information here is that almost 1 patient out of 4 had an infectious cause, but that relates to my first question of the case. You see, you have calcineurin inhibitor toxicity, a cerebrovascular event, or other metabolic disorders. So always consider non-infectious neurologic complications. Moving on to the third question. What next? What are the next diagnostic exploratory steps? I propose to you more CSF analysis with a PCR for in the CSF, so for toxoplasmosis, aspergillus, Mycobacterium tuberculosis, India ink stain for cryptococcosis. I didn't put it, but you can add PCR for cryptococcosis, specific PCR. So that's the first answer. Second answer is contrasted cerebral CT scan. Answer C is electroencephalogram. Answer D is more CSF analysis, but next generation sequencing. And last answer is magnetic MRI, magnetic resonance imaging, cerebral MRI.
Okay, so let's see if we can use the polling again. I don't have the questions here yet, so please show us the possibilities. Maybe until we wait, you can stretch a little more. What tests are you going to order for cryptococci? It's not in the question, so I can ask you now. Is it that only the multiplex PCR has a low sensitivity, or is it a problem with PCR in general? And we need to use completely other tests for detecting cryptococci from the CSF?
Yeah, that's a good question. You have more than PCR at your disposal for the diagnosis. So first you have classic mycology workup with the direct examination with India ink stain. Then you have the culture, but the culture can take very long time, so you can't really wait for that, but that's more confirmatory. Then you have also antigen in the blood and in the CSF. This is useful also for monitoring the treatment. And for the PCR, you can also do a PCR in the CSF. You can also do it in the blood if you think it's disseminated, the cryptococcosis. And the specific PCR has a better specificity than in the multiplex. So it's also useful to do that. Yes.
Thank you very much for this little answer until we were waiting. But now we have the question, and you're already putting in your suggestions here. And I think we are already very advanced in what we got back, and I will read out the results to you at this point. So most of you, 72%, are going for a cerebral MRI. Then 50% of you want to do more CSF analysis. So you're doing PCR for toxoplasmosis, aspergillus, tuberculosis, Indian ink stain. Then number 3, you want an EEG, maybe looking for status epilepticus. Maybe that's not telling us what the pathogen is, but might also be important. And then also 20% have access to next generation sequencing. I think that's very interesting. I don't think I would get this at my university if I ask for it, but 20% of you do, so that's pretty good. And 9% will do a contrasted cerebral CT scan. So maybe here's also the question, is MRI available for an intubated ICU patient in all settings? So yeah, maybe those, there are differences in different settings. Maybe you can comment on what you were doing with your patient. I'm very curious.
Okay, so what I suggest is to do more CSF analysis and to perform an EEG and a cerebral MRI. So contrast cerebral CT scan, I'll explain that in the next slides, is inferior to MRI. Okay, for the diagnostic workup of encephalitis, MRI is far superior to contrasted CT scan. It's so in some hospitals you don't have MRI, and sometimes the patient count is too unstable for MRI. So it's better to have a contrasted cerebral CT scan than nothing. But you have the choice. You must do an MRI. It's better and it's more useful for many reasons that I will explain just a little bit after. So EEG, it's easy to do. It's non-invasive. It's usually very sensitive but not specific, but that can help. And in the context of a patient with a status epilepticus, I think it's it's mandatory to do an EEG monitoring. As for next generation sequencing, I don't have NGS at my hospital also. So it's really it's third tier of the diagnostic workup for encephalitis patients. So usually we don't do it unless we don't have any diagnosis with a severe patient that is not getting better. But that clearly at this step of the case, I would not do NGS. So the patient had his cerebral MRI. You can see here several sequences. You have T1 with gadolinium, T2, flare sequence, that's the diffusion technique, and that's the ADC. So here what you can see is asymmetrical hyperintensities of temporal lobes. You can see pretty well here in the diffusion sequence, here and here. So that's the result of your MRI, okay? I won't say nothing more for the moment. And you also performed an EEG, which is this one. What you see here are abnormal patterns here. That are called, periodic lateral epileptiform discharges. That's PLEDs in short. And those PLEDs are located in the right temporal lobe. Okay, you can see that because you have here the even numbers are right derivations, and the odd are on the left. So the interpretation is right frontal PLEDs. Okay, so PLEDs, as I told you earlier, PLEDs are not specific of any pathology. However, they are seen in stroke patients and in infectious cause, and particularly in herpes simplex encephalitis. But that's not the only cause. You can also see it in metabolic etiology such as post-anoxic, dysnatremia, dysglycemia. So once again, not specific, but the location, that is very interesting, because not all those, except if you have a stroke in this location, this is very evocative of an infection of the temporal lobe, as suggested by the MRI of the previous slide. So that's the last question. So thanks if you can launch it. Given the MRI and EEG results, what is now the most likely diagnosis? I propose to you tuberculous meningoencephalitis, herpes simplex virus encephalitis, cerebral aspergillosis, posterior reversible encephalopathy syndrome, and cerebral toxoplasmosis.
Okay, so I can see that you can already insert your answers. Maybe until we wait for the results coming up, I have a little question. At this point, maybe you're sitting there waiting for the date for the MRI or the time slot where you can actually obtain your pictures. What do you do with the immunosuppressive medication in such a patient? So now you have some kind of an infection being very likely, you don't really know what it is, but the patient is severely immunosuppressed. Do you start changing that, or do you just close your eyes and stick to the plan? How do you proceed at that point?
That's a good question. Usually, the first part of the answer is usually we discuss with the transplant doctor of the patient. It's a multidisciplinary discussion. It depends on if the patient had already had rejection, what were the most recent treatments. But usually when we suspect viral infection, we try to stop, and it's not too complicated, to stop mycophenolate mofetil, the cell set. That's the first we stop for when you have a suspected viral infection. As for the rest, it depends. Sometimes we can lower the objective of a calcineurin dosage, blood concentration, but we only do that with the okay of the transplant doctor. But we try to lower the blood concentration. We do not stop them. That's not possible. It depends on which organ is transplanted. For example, we have the experience in COVID patient with renal transplantation. It has been done to stop completely with severe COVID, ventilated in ARDS, stop completely the treatment and lose the kidney. Just keep a very low steroid dose and lose the kidney to save the patient. But that's not possible if you have a heart or a lung transplant. So we can do that. The only thing we can do is lower as much as possible the blood concentration, the objective of blood concentration of tacrolimus or cyclosporine dependent.
Well, thank you very much for commenting on this topic. Now we have the results of your polling, and I will read the answers to you. 90% of you selected herpes simplex virus encephalitis, and 10% opted for cerebral toxoplasmosis. So there's a clear trend here, and maybe you can now solve the case for us and see if we are correct in the end.
Okay, so well done all. This was indeed an herpes simplex virus encephalitis. The MRI was very suggestive. The EEG was also very suggestive. The clinical history was suggestive. The only element that prevented us from doing the diagnosis earlier was that almost normal first CSF analysis and the negative PCR. So a new lumbar puncture is performed in this patient after the MRI and the EEG. You have now more pronounced meningitis with 42 elements, and you have a positive PCR for herpes simplex virus in the CSF. So that's the final diagnosis. So maybe just, we're almost out of time, very short learning elements. Cerebral MRI is really pivotal for the encephalitis diagnostic workup. If you can, you should do it as a first-line imaging technique as soon as possible. Of course, only when the CSF is uninformative. If you have the diagnosis with just the CSF, it's not necessary. You can see here in the herpetic score study of severe critically ill HAC patients, only 30% of scans were considered abnormal, whereas 98% of MRIs were abnormal. You have here the same patient with a CT scan and MRI on the same day. That's patient from Bichat Hospital. You can see clearly that the CT scan is completely normal, and you have a clear involvement in diffusion and in flare of the temporal lobe. That's the usual location of hypersignals in herpes simplex encephalitis. You have the temporal lobe, you have the insula, and also it's not less known the cingulum, which is this zone of the brain. Very quickly, because I'm a little bit late, MRI can also be useful as a prognostic tool. On the same cohort I was talking to you about, we showed that if you have multiple lobes involved, if you have a bilateral diffusion herpes signal or a signal in the left thalamus, this is associated with worse neurologic outcomes. And finally, CSF analysis can be deceiving in HAC, as shown in this case. In the herpetic study, 16% of patients had CSF cellularity below 5 cells, and 4% had a negative PCR on first testing. And a negative PCR in first CSF testing is associated to a delayed treatment by acyclovir. You can see here in blue that's the patient with initial negative PCR, and in yellow, the positive first PCR. And remember that all negative PCR were performed less than 4 days from symptom onset. So it's the early CSF analysis that can be negative. And this delayed treatment is associated with worse outcome, longer ICU stays. You have ici patient with the negative first PCR. It's twice as long an hospital stay than a patient with positive first PCR. And you have also more mortality, 27 versus 13, and also a poorer functional outcome at 3 months. So this is important to know, not to delay the treatment. And it's possibly, although it's not significant because of a very low number of patients, it seems that patients with negative first PCR were more frequently immunocompromised patients under steroids, and patients with HIV infection. So to wrap this up, key clinical messages: immunocompromised patient with encephalitis, always consider pathogens of the immunocompetent patient. They can also do Streptococcus pneumoniae meningitis. Don't forget that. Always consider non-infectious causes. They are frequent, 25% in the Swiss cohort I showed you. Clinical presentation can be atypical or abated, and likewise, standard CSF analysis can be deceiving. The diagnostic approach must be multimodal with CSF, MRI, and EEG. Don't hesitate to repeat these exams if necessary. And performance on molecular multiplex tests is excellent, but not perfect. Keep that in mind, and do not hesitate to repeat in case of absence of diagnosis. Thanks for your attention.
Well, thank you very much for this wonderful case and for staying in time. I have one question that I would like to ask you in connection to the case. So you talked about the problems in the sensitivity and specificity of viral diagnostics in the multiplex panel. So what do you do if you have a negative panel in a case like yours? Don't you also opt for a single PCR testing in this case? Maybe I missed it, but is that what you would do? Or do you say, well, if it's negative, we do another CSF draw 2 days later or 3 days later?
Well, it's a good question. In clinical practice here at Bichat, we usually perform a specific HSV PCR unless the CSF analysis is really is done early in the course of the disease. If it's done less than 4 days from symptom onset, we usually wait until 3 to 4 days to perform another CSF analysis, and this time we do the multiplex and eventually the specific PCR. But yes, the specific PCRs are more sensitive than the multiplex.
Thank you very much for clarifying this, and maybe also one question, maybe to both of you, because both of you touched this or stretched this point with the periodic pattern in the EEG. If you see that, would you also increase the anticonvulsive treatment in the patient, or doesn't it have anything to do with status-like condition?
I don't know if
Etienne, maybe you start.
Okay, so no, this is not the plates are not a pattern to be treated. It's just it's a diagnostic pattern, but doesn't need a particular treatment.
So it's not a status-like treatment, but it shows maybe encephalopathy in a certain area of the brain.
That's it.
The thing is, for the pleds, if I can add there is a continuum between non-ictal features and ictal features. And we know for non-herpes simplex cohort of patients that those pleds, either lateralized or generalized, are associated with a high risk of seizures, both clinical seizures and non-convulsive seizures. So this should not be a clue or a sign for starting anticonvulsivant therapy, but this may require intensive EEG monitoring because those patients are at very high risk of deterioration. And also, Etienne mentioned that this is a poor outcome pattern seen in many patients with different types of brain injuries. So if these patterns are present, we should be very cautious with monitoring.
Well, thank you very much for clarifying this also. And I think I would like to wrap up now because it's already 5 minutes after the time. I think we had a wonderful session today. Thank you very much to both of the presenters, Professor Sonneville, Dr. de Montmollin, for those excellent talks, for the very clear and distinctive learning items that you showed us. And I think we all benefited from what you brought us today. And I would also like to thank the audience for participating in writing those questions of yours in the Q&A section. I apologize for not discussing all of them, but there were just too many. And thank you also for participating in the polling. And so I wish you all a very good end of the year. Maybe we can also already say this, a very nice Congress. And thank you for being here today.
Thank you, Matthias, for the
thank you very much.
Sharing and organization. It's a pleasure.
All right. Bye-bye, everybody.
Bye.